Everyone wants to improve healthcare, but who do you trust enough to take your private health information and do things that are designed to make care better? Do you trust your doctor? Do you trust your health plan? Do your doctor and your health plan trust each other? I'm Andy Reynolds with NCQA. Today on Quality Matters, the first in a two-part series, In Data We Trust. This episode is titled You Can't Spell Equity Without IT. It's about uniting people, process, and technology to make care better for groups that traditional care has overlooked. Our story begins in Ohio.
I'm Tamara Ward, Senior Vice President of Business Strategy and Operations at Oscar Health. I'm originally from Cincinnati, grew up in Cincinnati. Cincinnati historically has been a very segregated city. My experience as an African-American female, growing up in the healthcare system there and seeing the inequities that occurred from my own community was heartbreaking. And when I joined Oscar, I felt I was in a position to lead and drive change.
Oscar is known as an insurtech company. I asked Tam Ward what that means.
We're a combination of a technology platform coupled with a traditional healthcare insurance company. And the reason it's tagged InsurTech is we use those two things to refactor healthcare. I spent many years in a traditional healthcare environment, and I say that Oscar was built by folks that were not in healthcare. A lot of our team had no healthcare experience, which is why they were able to build technology that was intuitive and that operates as a trusted advisor. So when you're figuring out which product you want or which network you want, we're that advisor for you because of how we built that technology.
Many healthcare enterprises target wealthy, mainstream consumers. Oscar went in another direction.
Most of our membership sits on the ACA. And the ACA consumer is price sensitive. At times, it's their first time having health insurance, and it's their first time really navigating the healthcare ecosystem. And through better understanding our membership, we've done a lot to help drive the needs of underserved and low-income areas.
I'm curious about culturally competent care and what Oscar is doing to ensure access and equity. How are you ensuring equitable access to care, especially in underserved, rural, or low-income?
We started a program almost 3 years ago called Culturally Competent Care to curate networks to meet the needs of specific populations. So imagine you are an African-American male looking for African-American male physicians to receive primary care services. We've done the work to acquire data to help you navigate that need.
Tam and her colleagues at Oscar found that the more they learned, the more they were able to parse their data into finer slices and the more nuanced they could be. That led to the creation of a service called Hola Oscar.
Imagine being a Spanish-speaking member in Georgia. You may live in a rural area and you may have specific diabetic needs and prefer to receive your information translated in Spanish. I had a portion of our team that was Hispanic. They were sharing with us their experience as a Spanish-speaking consumer with healthcare. And we partnered with our employee resource group internally called Hola Oscar to help us understand how to best curate this experience. We learned that everyone that is Spanish speaking is not always speaking in the same voice and tone. And some words that may be translated from Spanish speakers from Mexico is different than your Spanish speaking population from Puerto Rico. And so we started addressing the voice, the tone, the translation of all things that we do into a Spanish first solution that incorporated these differences. We have invested in the cultural experience for our Spanish-speaking members in a way that feels more like a trusted family member. And so Hola Oscar is our first end-to-end curated and personalized experiences for a certain cohort. Our net promoter score for the bulk of our population is 66, and the industry is at 3. Our net promoter score for our Spanish-speaking population is 87.
I understand Oscar is building culturally competent physician networks and creating a provider database to enhance population health. My question is, what is the relationship between those two initiatives and how are they going?
Yeah, they're interconnected because you can't have the network without the data. And when you ask, how is it going? It's been a journey. When we started Culturally Competent Care, and our desire was to build culturally competent networks, we did not understand how big of a data gap we had in the industry's ability to share race and ethnicity about its providers. Let's just start with race and ethnicity. We started to seek out allies that agreed that having this type of information was helpful to make a meaningful connection between the member and the provider. And so we went to state-based regulators and told them about what we were trying to do, and we advocated for them to share this information with us. Some did and some didn't. And for those that did, it allowed us to analyze our network and understand where we had gaps. And a great example was in Texas. We received the data and we recognized we have a huge Vietnamese population in Houston. But we did not have a reasonable amount of Vietnamese physicians. Now, I'm not assuming that every Vietnamese member wants a Vietnamese physician. However, if that is their desire, we didn't have it. And it was a real gap. And so we kicked off efforts to locate the providers that had both experience and or profile to enrich our network. But we recognized when we tried to do that at scale across the country, it became difficult because of gaps in the provider data. And so we saw organizations like the American Hospital Association to enrich that data. We found not everyone collected the data. And we ended up revamping our credentialing processes to ask for that information when it was time to re-credential providers. And so over time, we've been able to improve our provider data, which then allows us to improve our networks. But if I'm being honest with you, we're not where we want to be. And if there was one ask I could have of those in a place of influence to help create standardization around provider data, it's share the attributes of the physician that are important to the patient and hold us accountable for doing what's right with that information.
In situations where providers' demographic data hasn't been available, have you found that's been more of a can't or a won't?
I think it's a mix of both, and until they start asking for it, they're not going to receive it. There's also a fear of what is the insurer going to do with this information, and a lack of trust that insurers are going to do right with the information that they receive, which I understand. I used to be on the provider side before I joined the health plan, and my perspective there was health plans are just here to not pay me. And then I moved to the health plan side and I realized they don't wake up every day thinking about how to not pay a provider. And so there's this mistrust that all parties, I won't just say providers, all parties fearful on sharing information based on what they believe could happen with that data. I think we've been able to positively influence that in some areas, in some we have not.
How do you build trust?
You build trust by starting with building the relationship and helping people understand why. If I'm able to sit in a room and speak on what we're doing, why we're doing it, why I'm passionate about it, then I think that you could overcome the first hurdle. And then I think the second piece is you have to deliver. So if I commit to you, if you share this data with me, I'm going to help advance my networks, and I never do that, then it's hard to believe anything else that comes out of my mouth. But if you can first help people see what you see and understand from your point of view, that's the first hurdle. I was like, do we all agree that this is a problem? Do we all agree that sharing this information could be beneficial to members? Do we all understand that there are scenarios where people can use this information for bad, right? And can we lay out how we'll mitigate the risk? And if we lay all of that out, you get all the angst and anxiety out on the table, then you can start to work to a solution. Then you have to just deliver on what you said you were going to do.
I asked Tam for an example, and the discussion turned to behavioral health.
We found when we were mining the data that we had a lot richer data on race and ethnicity as it related to behavioral health providers. In the behavioral health sector, I think sharing race and ethnicity data is more expected. That specialty, they're a bit ahead as it relates to the importance of social and demographic factors. The behavioral health network developers were thoughtful about requesting that information at the very onset of having that provider join their network. And it's not just the race and ethnicity data, but they collect data on cultural competency. They collect data on if a physician is LGBTQ plus friendly or not.
What is Oscar doing with regard to care of LGBTQ members?
A few years back, we created a program called My Identity. And My Identity was started to really help us show our support of the LGBTQ plus community by allowing our members to self-identify as they onboard onto our health plan. Then allow our physicians, our customer service team members, when they engaged with that consumer, to address them how they wanted to be addressed. As we started My Identity, it was also important for our LGBTQ plus community to understand their access within our networks. And so we began collecting data on providers and facilities that were LGBTQ plus friendly. We heard from members that I'm going to X, Y, and Z facility and they don't treat my needs. It was a horrible experience. And if you think about that experience on a human level, no one wants that to happen. So we went down the path of collecting that data and updating our directories to help with that navigation.
Oscar's focus on sexual orientation and gender identity caught the attention of NCQA.
Hello, my name is Megan Stanhope. I am a digital marketing manager here at NCQA, and I also co-chair our LGBTQ plus employee resource group. The recent study from the Kaiser Family Foundation identified that roughly 1/3 of LGBTQ identified adults don't feel comfortable going to the doctor because of negative or discriminatory experiences that they've had. And so anything providers can do to make folks feel more comfortable, such as using the correct pronouns, having this knowledge of their experience, is very helpful to making LGBTQ folks feel more comfortable in those spaces. It may seem small, just these data points that are being collected and using people's pronouns, making sure that their conversations align with the data received. But those things really do go a long way in building trust and creating better experiences for LGBTQ plus people and rebuilding that trust in the healthcare system.
Hi, my name is Jules Reich. I'm a senior healthcare analyst in population health at NCQA. Research shows that disparities persist for LGBTQ plus patients at varying levels of the healthcare system. They often are disparities around healthcare that's not related to sexual orientation or gender identity, as just taking care of themselves as a person. We know from the 2021 National Institutes of Health study that patients who identify as LGBTQ plus are less likely to receive certain types of preventative care, including cancer screenings. And this can have really significant ramifications down the line. So it's really important that we use the data that's collected to ensure that healthcare is being equitably accessed by all.
What myths or misunderstandings do you encounter as you speak with regulators or other people in the industry about data collection?
Many regulators don't believe we're really doing the work. Like, you really want this data? You really want to focus on curating a diverse network? And we're like, yeah, we know it's kind of crazy, but we think it's the right thing to do. When we're able to have that conversation and help them understand why we want to advance healthcare equity in a way we're trying to advance it, and then we deliver on what we said we were going to do, it builds that trust. And so if we can build trust with one regulator, that then We have an example when we're going into another room with a regulator where we may have had opposition. We use the results to open additional doors to help change the heart and the minds of those responsible for determining the rules. I shared with you, Ola Oscar was our first end-to-end program we deployed. We want to do hundreds of those. And we have to take the results and reinvest that into the next program. It could be focusing on men's health services next, or the LGBTQ plus community next, or the Indian community next. That is, every year we've made a commitment to continue to invest in delivering personalized products.
You joined Oscar about 4.5 years ago. What do you know now about culturally competent care that you wish you had known then? And have you changed your mind about anything?
For me personally, culturally competent care was a bigger why for me in being in healthcare. This isn't my day job. It's something that I'm passionate about and gets me excited every single day to know that I'm in a position to help drive the change that I want to see. And so for me, if you say, is there anything that I would have done differently? Probably more, but I think I signed up to be the change that I wanted to see. I knew that it was going to be hard. And I think for anyone engaging in healthcare equity efforts, you have to know that. And you have to be relentless about continuing to do the work. I talk a lot about pilots because we're going to fail sometimes. We're going to get it wrong. But that doesn't mean we stop. The most eye-opening experience as an African-American female, as we started culturally competent care, I started to realize that there are so many populations that have similar experiences that look nothing like me.
Say more, please. What's an example?
I'll use the LGBTQ plus community as an example. It doesn't feel good to walk into an office and feel like you don't belong. And I really resonated with that when I could hear different groups of our population and their experiences in healthcare. I have a unique experience. You may have a unique experience. The person across the table from us may also have a unique experience. And we as a industry, we have to work to personalize healthcare so that we can address those unique experiences to help influence their healthcare outcomes. And so I don't think that I would change anything. I've learned a lot, probably more than I thought that I would sign up for. I didn't think it would be this hard. I thought it was really simple. It's really easy on paper. And I think as long as I'm in our industry, these are the things I want to advocate for.
I think that's a great place to wrap things up. Tamara Ward of Oscar Health, thank you for your time.
Thank you for having me. I hope that you guys continue to create a platform for us to have these wonderful conversations.
That's all for part 1 in our 2-part series, In Data We Trust. Today's episode has been called You Can't Spell Equity Without IT. Next time, our conversation takes a surprising and controversial turn. We'll talk about sex, privacy, and whether lawyers have a right to know about your sexual orientation and gender identity. We'll ask, who do you trust with your private health information? Join us then.